The topic of debate is, are we over-treating hypothyroidism in pregnancy? So I have to play the role of a bad cop and I have no choice. So I'll try to defend my role the best, although we all know the truth, I believe. So yeah, so I'll be for the motion that indeed we are over-treating hypothyroidism in pregnancy. So I'm not entirely against treating hypothyroidism, just making myself clear. So not against treating hypothyroidism in pregnancy, but let's be clear, what is clear. So where we can treat, where we must treat in fact, and what is the controversy. So what's clear is untreated overt hypothyroidism in mother will definitely, I mean it has enough evidence that it can impair the IQs or the brain development scores in children. So, but later on a lot of studies came which showed that milder forms of hypothyroidism when treated or not did not actually make much of a difference in the brain function. So this led to a lot of controversial phenomena or the ideas like, is the tighter TSH, is the TSH targets existing by all the societies, is it too much? So that was one of the controversies. Other controversy is treating subclinical hypothyroidism in pregnancy. So is it really needed to treat all of them? And the last one is in euthyroid women, euthyroid pregnant but just antibody positive. Is there a need to treat? So I think these are the three important controversies and which I am going to argue for. So the first one is about the tighter TSH targets. Is it too much? So American Society quotes 0.1 to 2.5, that is the tighter cutoff for the pregnancy in first trimester as a normal range. And they say when TSH crosses more than 2.5 in first trimester, more than 3 in second and third, we are supposed to treat. And similar recommendation is given by the European Thyroid Association also, which is way too tighter compared to the normal upper limit, say 4, 4.5 or even 5 in some of the lab reports which we find. So ethnic differences are quite clear. So that Asians have a higher TSH in general, even compared to black women may have even lower, but compared to white women, Asian women have a higher TSH. Maybe this is one of the reasons why the Indian recommendation suggested that, this is just one of the reasons, that maybe the first trimester TSH can be expected, or accepted up till 3 and second and third up till 3.5. But again, we still, stick to the ATA guidelines only, which we just spoke, that's a 2.5 in first, 3 in second and third. So I would say current approach is so proactive. So proactive because in patient's perspective, if we don't treat and the outcome is not good by, some issue. So patient might have that anxiety that it's probably because of the untreated situation that happened. So to overcome that patient anxiety, doctors usually go ahead with the treatment. And from doctor's perspective, obviously we don't want, to avoid all the litigations and stick to the guidelines. That's the reason I feel we are very proactive. But is there a real need? That's a debate. So guidelines, I agree, it is said to be followed, but what are these guidelines based upon? So the basis for current guidelines. So American Society recommendation was based upon these 6 studies. And just 6 studies, okay. So and these 6 studies were actually heterogeneous because 4 out of these 6 studies only they reported the actual ranges, which is supposed to be, the NACB is the guiding, the guideline setting agency for this, for the, upper limit and lower limit. So they recommend 2.5th and 97.5th percentiles as the limits. So this was followed only by the 4 studies, and even that was varied in the sense some of the studies had ranges from 2.3 to 3.6, one even had an upper limit at 5. So out of the 6, so much variation. And 2 out of the 6 studies had less than 100 participants, where the minimum recommendation is at least 120. And even the Indian recommendation says thyroid function tests need a minimum of 400 individuals because thyroid functions are known to be notorious. A lot of variation happens, so at least 400 individual measurements are required. So unfortunately, these had less than 100 participants, and none of them had measured urinary iodine. So we know the importance of testing urinary iodine concentration in pregnancy because iodine was at least one of the major factors for thyroid function dysfunction. So Indian studies also say, there are good studies, so which also say that a TSH cutoff of 3, which is recommended by Indian guidelines, may also be less. So 3.1 to 6 could be still okay, and another study says maybe it could still be extrapolated to 6.2. So a value above 6.2 could be taken as a subclinical hypothyroidism. So this is what Indian studies say. So again, the controversy still doesn't stop this. Even if we take a cutoff of 6, do we really need to treat that subclinical situation? That's the question. So subclinical hypothyroidism, what's the evidence that this situation causes harm? What is the evidence? So Endocrine Society guidelines says, the left hand side says that subclinical hypothyroidism can have adverse obstetric and neonatal effects. So the evidence grading, they themselves mention that it is fair or poor, in the evidence grading. And the rationale for treatment also is mentioned as potential benefits outweighing the harms. So it's not a clear-cut opinion, and they say that the current opinion is because maternal subclinical hypo probably contributes and may have adverse events, and there's no clear evidence that this can actually be prevented. So even if we treat, are we really preventing a adverse event, or are we actually preventing a fetal brain development? That we don't really know. So obstetric effects also, it has been, we are seeing two large studies. One is a review of 10 studies and one is a meta-analysis. So in the review, 4 out of 10 studies showed a positive association with preterm delivery, whereas the meta-analysis also states towards the end that increased risk of pregnancy loss, preterm delivery, all these things are there. But again, if we go into these 14 studies in detail, they don't really stick to one single cutoff. Some studies have 95th centile as the upper limit, some has 97.5, some has 98. So a lot of variation in these studies actually, and even the numbers among the huge numbers they state initially, ultimately just 1 to 14% to actually have hypothyroidism, and the placental abruption was present only in one study. So I think there is no solid evidence as to are we really preventing the obstetric adverse events by treating. So neonatal effects have even a lesser evidence, that's a large multicenter RCT. So that was done in a huge number, and ultimately it found that there was no significant effect of the on the offspring IQ, and that was actually follow up. Even after the birth, the children were followed up to 5 years, and this was the result. So Lazarus, who was a part of this RCT, so he said that maybe the idea that subclinical hypothyroidism might cause a neurocognitive deficit is biologically plausible, but again not clearly proven. So ATA shows us the left hand side, what it doesn't show also will be seen. ATA says that 2 large studies in southern Italy that showed whenever women with the TSH of 2.5 to 5 were left untreated, some of the pregnancy losses were seen, and thyroxine treatment in such conditions where anti-TPO was positive would be beneficial. So what it doesn't show is actually the same time, almost the same time these studies were published, there were 2 large studies which had opposite conclusions. So one is a faster trial that showed that there was no much of a adverse event, that are the obstetric outcomes, and the another birth cohort that said the women who had subclinical hypothyroidism in pregnancy, so they can develop a frank hypothyroidism later, just like how we say GDM patients over the long run they'll develop diabetes. Similarly, those mothers had an effect, but not really on the children or on the offspring. So that was the outcome. Isolated hypothyroxemia, I am sure all of us agree that it needs to be treated. So definitely first 12 weeks the child the fetus doesn't have its own thyroxine. So if T4 is low, we have to treat, but on what basis? Because most of the times what we ask in the lab is a free T4. So that is all we which is available to us. So what is the reliability of FT4 immunoassay? So most of the time this FT4 is told as not suitable as per the guidelines to actually diagnose isolated hypothyroxemia, because this important one of the landmark studies. So that's it, a total T4 or a FT4 index, that is much more reliable. We are all aware of the inverse associations, right? So if the T4 is low, we expect the TSH to go high. So that inverse association, that was maintained with these two, total T4 and FT4 index. If it was low, TSH would be high. But that was not the case with free T4, because free T4 was found to be actually lower in first trimester despite the TSH being normal. Second and third trimester also it was even lower. So we rely upon free T4 levels to diagnose a patient with the isolated hypothyroxemia. Maybe that's when we are doing the mistake and not the concept per se. So that could result in overtreatment, and we know, overtreating is definitely not good, because neurological consequences like ADHD and all could definitely happen later. So the last part, should we treat a pregnant woman who simply has antibody positivity but euthyroid? So what is the opinion on this? We very commonly get this reference because especially if they have a history of infertility or recurrent loss, just because of anti-TPO positivity, earlier ATA guidelines that said maybe starting a dose of 25 to 50 microgram is safe, and it could, in recurrent pregnancy losses it could help. But it was actually waiting for 2 large trials to come out. So the 2 large trials are these. One is a tablet trial and one is a T4 live trial. So tablet trial said that there was actually no difference in the primary and secondary outcomes. So the primary outcome was the adverse obstetric outcomes, and the secondary outcomes were actually the outcomes on the neurocognitive development. So there was no really difference, you treat it or not, just because of anti-TPO positivity there was no real difference. Similar was the inference in T4 live trial, and they said we do not advise routine use of levothyroxine in women who are antibody positive even if they have recurrent pregnancy loss and they have a normal thyroid function. So we don't really have an evidence at the end of this. So routine T4 has no benefits on the obstetric outcome. So I would say there is no controversy on all these aspects. So I would invite Dr. Saurabha for the rebuttal.